Happy Tuesday.
Happy Tuesday, Latif.
How are you doing?
I'm doing fine, and thank you for having me.
Good to see you, but on this side of the year.
Good to see you, and Happy New Year.
We're still Happy New Year.
Yeah, we're still.
Hey, it's Happy New Year.
Come after Jonana, then it's Happy New Year.
It's a new year. It's a new, you know, Mariam.
Yes,
of course.
I know Mariam.
You've been on the Nation FM fix, eh?
Yes.
Morning fix on Nation FM.
Yes.
And you know Janet.
Yes,
Of
I do,
course.
yes.
8 years ago.
8 years ago, similar role. 8 years
Yeah,
later, a lot has changed, a lot remains the same.
Yeah. So we're going to have all these conversations with you today about, the state of healthcare from a doctor's perspective, from, your members and what your members are saying. And as we do that, Dr. you are a doctor, which takes us back into you are an A student, which, took you to university statement. So you know very many things. But there are some words that are said that, come and go, and you don't think about them until they're brought back to you later. And Janet is about to bring back some words to you this morning.
I love how you tied that thread together. You're a doctor, must be an A student. Yes, what we do is just reflect on powerful words and just try and have a conversation about who could have said them and what they mean to you. And so for this next quote, this was said by a pioneer in fighting for our environment, an African. So I think we can already begin to think through who that was, somebody who was a very powerful person who fought for our environment. And this is the quote: "It's the little things citizens do. That's what will make the difference. My little thing is planting trees." Who said that?
Professor Margaret Wangari. Yes.
Wangari Maathai.
Wangari Maathai.
Yes, absolutely. She said that
It's the little
it's
things.
the little things that citizens do. That's what will make the difference. Her little thing in fixing the nation was planting trees.
Yes.
What's your little thing, Daktari?
My little thing is to ensure that there's justice for all Kenyans to access the better healthcare by ensuring that each doctor, wherever they are, they're supported to offer their services. And that's what we do every day in the union.
Yes.
That's your little thing.
That's my little thing.
So your day job is actually at the union.
At the union, full-time.
That's your full-time job.
Yes, that's full-time. And it's a work that goes on sometimes 24 hours. You have in the morning to the night, and it has no order. Yeah, it operates we'll say in chaos, because there are issues that are pertaining to patients every day, the issues that are pertaining to doctors every day, and in every place in the country.
So how much has that chaos evolved, given a lot of what the doctors, the medical facilities are grappling with, issues around access to services, insurance, patient healthcare? What's in your entry today, for example, at the office?
For example, today we have a meeting around 10 a.m. To discuss the plan for posting of the new lot of intern doctors. It is the intern issue. For example, for last year, we had 1,200 interns who were posted and wages reduced. Again, everybody realized that this issue was resolved. So to people, the issue of internship is done. But to us, we have a new lot that graduated last year, November, who need to be now replaced. So that's they're now 1,284.
Who graduated in November?
Who graduated last year, who again now need to be placed. Yes. Today again we are also having a plan on giving a conversation on World Cancer Day. Yes. Because at the end of the day, it's about access, about prevention. Many say that the awareness is easier through awareness it's easier to prevent some of these cancers. So that's resolvable today. The other thing we're discussing today is we are planning what we call the insurance. We have this social health authority that was giving insurance. Previously, we have what we call civil servants, but now we have social health authority, and there's part of now doctors themselves not able to access care. So we have a group of doctors that we're meeting with in the office to analyze that. Okay, when the government procured this comprehensive cover for the civil servant, is it working? Then the last thing today on our table, but this was in office, is to discuss an issue of doctors who are being paid a third of their wages at Madare Hospital. And then also the last thing is we are launching a strike in Moi Teaching and Referral Hospital, a strike that is to commence tonight, midnight.
All right.
Yes.
We'll come back to the strike, to the doctors being paid a third of their wages. There's a lot to unpack from your intro, and it's a really busy one. But I just want to reference the conversation we had the last time we spoke when doctors were on strike. You said something that stuck with me, because I kept pushing at how do we, make sure we take care of the doctors, but we also, take care of the patients, etc. And he said one thing you're keen on as KMPDU, as Davji, is no man will be left behind. The return to work formula that you came to seems to have left the intern doctors behind. It seems like everybody else's needs were addressed except for the intern doctors. Did you leave them behind?
Oh, Miriam, you're behind news.
Tell me.
Okay, in strikes, when we go on strikes or when we go on demonstrations, the essence of it is to bring the government or the employers to the table to discuss the matters. On 8th of May 2024, we had an agreement with timelines for these things to be implemented.
Yep.
To many, because those things are not instantly done, it was a failure, and then interns were thrown under the bus. But then we had a conversation. It was to be 60 days, but it took about 4 months, to the point that interns were then posted on 1st of August 2024. But the payment issue was still pending. Yes. So because of this discussion, court made a judgment that indicated that as a union, we cannot resolve your problem. Go negotiate with the employer, go discuss, use your mechanisms to sort it out. But the government responded by paying the interns the 40,000 reduction by around 80%. And we issued a strike notice again last year on 3rd of December, which now led us into the table with conversation. That strike was suspended on 22nd of December last year at the Deputy President's office, where the interns are being paid their full wages, their full salary of as per the CBA, 206,000. And they were paid, that are payable in December, in January, and the arrears for the months that they were paid less is being paid this month. So essentially, we did not throw interns under the bus.
So the conversation with the DP
Yes.
Earlier, it was in December. It was late
It was in
December,
December
right?
22nd.
Was now the one that reverted to the original agreement in the CBA.
Yes.
And you're saying that your members have confirmed
Yes.
that they received the proper pay in December and
Yes.
in January.
Yes.
Without delay.
Yes.
And now you're saying that the commitment is the arrears are to be paid in February.
Yes.
With the February salary or in February before the salary?
The issues that we were actually striking for are things that have been that had not been done for a while. For example, the intern issue was new. This one was the lowest we have been as a union, where the government just wakes up and reduces their wages.
Yep.
So it was a big thing for the union. And therefore, when you are suspending the strike, we wanted to see an evidence of a payslip that have reinstated the payment as per the CBA, which was done. So as of January, February, the payments have been reflected as per the CBA. But that was for the cohort that are already working.
Yep.
So again, when they were trying to bring that conversations in our meetings, we told them we can't entertain that, because there's no any provisions that says employees' wages need to reduce. But they have been hell-bent on that. So that's why we are a bit keen. The other thing that we achieved also with that
This
strike,
was only for the cohort that were already in, not
Yes.
for any incoming cohorts.
that was the cohort that was in at that were posted in August last year. We did not discuss the fate of the current or cohort that we have meetings with today. But essentially, the reality is that whatever direction court gave us, is that we have a CBA that is valid, and therefore there's no way the employer will come back and reduce the wages. And that's why we had a strike, and we were ready to go for another strike. The other thing that happened was there was this basic salary for doctors that had not been paid for 7 years. We had had engagement with government for 7 years and nothing happening. It led us to that 56-day strike. I think it is in December we also again demanded that we were not ready for promises. We wanted to see the money in the account. And by the time we were suspending the strike, doctors in Kwale County were paid. And then the doctors in the entire country got 50% of the amount that was owed for 7 years in December and January. So
That's not to belabor, and maybe this has been covered. I just want to understand where the consistent delays are. What can you pin that on? Because 7 years of demanding something that's within right, and then having to constantly have some of it paid, some of it. Where exactly would you say is the major holdup when it comes to this main issue?
The biggest, and I would say that government or employers sign collective bargaining agreements with employees or with unions with no intentions to implement them. Whatever they always do is to handle the crisis at the time. It's not only with doctors, it's also with other unions. That's why if you look at the history of this country, CBAs are just being signed and put in the closets without implementations. And that's why as a union we say there's no need, there's no value in having a paper or document without having it implemented. And that's why we have always insisted that agreements that we had, yes, it's 2017, must be implemented in total before you ever sit down to discuss and negotiate a new document. So employers, government in itself, are just there to handle chaos. In fact, without strikes, like now, as I told you, you're going to have strike in Moi. Yeah. Without that strike, nothing can happen. So
nothing moves.
Nothing moves. So if you're a union that can't strike or can't give notices, can't demonstrate, then you better shut down. Yeah.
I want to put the context of the importance of interns.
Yes.
Okay. So we had like this cohort of 1,200 plus interns who graduated last year and they've been posted. This year we expect another 1,000 plus again who graduate and they need to be posted. What percentage of the workforce in our health facilities across the country do these interns constitute?
The interns constitute about 30% of our health workforce. And in terms of the revenue generation in the hospitals, if you go to any level 4, level 5, or level 6 hospitals, the first doctor in contact, you get contact with, will be that intern doctor.
Okay.
Will be there daytime and will be there at night.
Okay.
Yes.
Now, the other side is even when the government was pushing back on the issue of interns, they were saying, these are just interns. So let's take back. So this is somebody who, in Standard 8, they were hoisted high and they said, I want to be a doctor. In fourth form, they were hoisted high, I want to be a cardiologist. Right?
Yeah.
How many years do you take for your basic degree as a doctor in Kenya?
For now, the University of Nairobi, you take 6 years.
So 6 years.
Average 6 years.
And then you graduate with a bachelor's of medicine and surgery.
Yes.
And that's when now you become a doctor.
Yes.
But you have to intern.
You have to intern.
According to the law.
Yes. Actually, in the KMPDC, the Kenya Medical Practitioners and Dentists Council, it's an employment. And it is not only in Kenya.
Yep.
If you go to US, you'll find the Committee of Interns and Residents. If you go to Australia, you'll find the same. If you go to UK, you'll find the same. The only thing, the name in the UK will be the Foundation Doctors. And actually, without that, then you, because medicine is just a skill, it's apprenticeship. You have to learn and improve continuously. And when you become a medical officer, there is a consultant. And when you become a consultant, there's somebody who again was specialized further. So it's a continuous team playing skill.
Yep.
And therefore, when the government was trying to reduce this issue and say, no, these are students, to us, in a way, we realized that there was a problem. And it was not... It looked like an intern problem, but it was an intern problem. It was a well-crafted issue to reduce the wages of doctors and the workforce in the country.
It's to minimize the doctor.
Yes.
Because this person is a doctor.
Yeah.
They are not going for internship on their third year.
Exactly.
Yes.
They've graduated. They're doctors.
They're medical
Right.
doctors. What you've spoken about also speaks to the mental health challenges that a lot of doctors are facing, specifically intern doctors. Unfortunately, we've had cases of intern doctors losing their lives by suicide as a result of sometimes the frustrations of the job. As a union, I know we're fighting for the wages and making progress and inching forward. Is there another way? Is there any other way, any other form of support that can be offered? Because they'll say, okay, maybe the pay is a little bit better now, but my working hours are just... they're nothing like has ever been seen before, right? I'm unable to sustain myself financially, physically, to stay standing, etc. What else can we do for intern doctors and doctors as a whole? Because I know that's a problem that cuts across the healthcare system.
Last year, we lost about 8 doctors due to, by suicide. And I think about 4 of them were interns, and 4 of them were 2 are the general doctors and 2 are even consultants. And the whole idea is about the working environment. Right. Every time when a doctor works in an hospital, your role is to ensure that the patient gets the best care. You are supported to ensure that the patient is treated. But when you know very well that this patient you will have been able to help, to treat, and to actually discharge, and you've not been supported, and you've lost this patient, as a doctor, there's part of you that you also lose.
Yeah.
And that's something that many people do not see. As a doctor, you are a human being. You have emotions, you are feeling. So if the hospital doesn't give you leave, we have a doctor in Nakuru who had worked for 3 years without any leave. When he asked for leave, he was told, no, you can't go on leave. That happens. We have a doctor who you offer services, but then when you are sick or your child is sick, then you have to go to fundraising because the medical insurance is not working. So all these factors, the financial aspect of it, all these factors generally contribute to the mental meltdowns that we see. And essentially, in every setup, as a union, we've been asking doctors and employers in every place that there has to be time for debriefs, the time to reflect and see to it that is this working environment really supporting the doctor or just bringing out more stress to them? Right. Because we tried to investigate all these cases that happened, and it was boiling down to the working environment. It was boiling down to the shifts that you realize that a hospital has only one doctor, like we saw in Kirinyaga, where the whole theaters are being run by one doctor, one surgeon. So, and you're working under threat.
Dr.
Yes.
Our health sector is heavily regulated.
Yes.
There's KMPDC.
Yes.
That says this is what you must do to qualify
yes.
as a doctor in Kenya.
Yeah.
That includes even you study, you must intern under the supervision of a senior doctor before we even license you then to practice.
Yeah.
Are there regulations in place that says how many hours a doctor can work in a day or in a week?
There are regulations.
What do they say?
And if you look at even the collective bargaining agreement that we signed, the CBAs, it stipulates that the working hours are 40 hours a week. And that's not only for any work, it's also for the doctors. But then you realize that in almost every facility or every hospitals, they at least they do almost 100 to 120 hours. And that's what brings me to the question you were saying before I came to this part, that some ineffective and incompetent leaders or employers in the counties always find it easier to have blame games on the doctors. And if you get keen one-on-one to ask them, okay, you're saying your doctors are doing a private practice at the same time are working in the hospitals. Where are those doctors? You'll realize that a county in its entirety has less than 50 doctors or less than 100 doctors. And those are the ones who make the whole noise saying that doctors are not working in those facilities. And again, we always say, at one point, we asked one of the governors and the counties that if you're saying that your doctor who works in the facility has not been reporting to duty, there are HR procedures and manuals on how to handle abscondees. Are there any documentation of the same? Then you realize that there's none of that. So yes, it is a narrative that is always being put, or a perception that is being created, when essentially there is no plan within those counties or employers to employ the doctors.
But I want to get back a bit into it.
Yeah.
So is there specific regulation on paper that says 40 hours outside of the CBA?
Yes.
So this is in law.
It's 40 hours.
It says 40 hours is
yes.
how long a doctor should work.
Yes.
With our current,
Yes.
sorry.
Can our health system support that?
Yeah.
The number of doctors that we have,
Yeah.
including the
Against the number of
30% of services that are offered by interns,
Interns, yeah.
can those doctors realistically work 30 hours a week?
40 hours.
40 hours a week.
They cannot. For example, Kenyatta National Hospital, that has consultants that are employed, over 200, that has medical officers, that has registrars,
Yep.
that has almost 500. When we had an agreement with the government last year, May, that the doctors, including the registrars, need to work 40 hours, the hospital was almost shutting down. So it is not possible. And when you look at the ratio we have now, the ratio of the doctor to the patient is 1 to 17,000. Ideally, as per WHO, it should be 1 to 1,000. It means that with the 1,000 doctors that graduate in this country every year, it will take us about 40 years if we employ all of them to actually have the right the right ratio. So whatever it happens, even if all the doctors, because the doctors who are in clinical work,
Yep.
all the doctors are working, and we will still need like 40 years to employ 1,000 every year.
So then, as a union, there's also the other side of you're fighting for the doctors to get their fair wages, but clearly we need more doctors.
Yeah.
What are we doing to champion that and to make sure that we're not going to bridge this gap in 40 years? That's too long a time. To make sure that if it's 1,000 doctors graduating this year, it's 2,000 next year, or we're not losing any to the cracks in the system, whether it's going outside looking for greener pastures or just staying at home because they haven't been posted.
And that's what brought about this issue of the presidential task force and the issue of the human resource. Ideally, with the devolution, before the devolution, or that's before 2013, every doctor that was graduating was getting employed by the counties until 2016. Where now counties, on one side, they have high demand of the doctors to be employed. But on the other side, they're saying they have less budget, that within those limited number of doctors they have, or health workforce they have gone beyond the minimum wage, the maximum wage that they can use. So it means they can't employ, but then the services are needed. So we have a trend where doctors now graduate, but they don't get employed, not because they are doctors, but because there's no finances within the counties. So we keep saying, and it was part of our return to work agreement, the government to employ at least 2,000 doctors for start, and then 1,000 every year. It was a proposal.
So do first a big 2,000 doctor recruitment.
Yes.
And then every year.
That was actually in our return to work agreement.
Absorb 1,000 every year.
Yes.
What would that cost?
Go ahead. No.
Because you're saying that the challenge right now
is
that we cannot afford it.
No, it's not about they can't afford it.
It's that we
it's
don't
about
have
that
budgetary allocation.
counties not able to afford, as they claim.
Yep.
And also the national government is very good at the rhetoric or the PR of the universal health care without really funding it or financing it as expected. So there's no priority to employ the health workforce. And this I may take you back even to the manifesto of the president. It said they will employ 20,000 health workforce, which has not been done. And to employ 2,000 doctors at start will cost about 4 billion. To then employ 1,000 doctors every year will cost it's cost around 2 billion. So it's not an amount of money that cannot be afforded. It's just an issue of priority and an issue of when we talk about universal healthcare, when we talk about healthcare access or service delivery, do we look at who is going to provide these services in that facility? Because then that brings us also to the aspect of the devolution, which in its way brought a lot of brick and mortar aspect, where we have many facilities, the level 4s, level 5s, that have been built across the country. But if you go to that facility, will you get the care? Yeah.
I know that we shortly have to go to a break. I wanted to quickly ask, and maybe you can answer it later, if you've mentioned, was there talk of a National Health Commission that was going to be able to help mitigate some of the issues that medical practitioners are facing? Those were some of the recommendations. Can you speak to that, yes. The National Health Commission?
If you look at 2011, 2013, when doctors went on strike in 2013, the demand was not for financial increase. It was that they wanted an health service commission, which was in the Boma's draft of the Constitution and then changed in the Naivasha draft. The essence of that is that we have actually seen that in 10 years period when there's the devolution of healthcare, the employment of doctors, the promotion of doctors, and all other health workers is subjective, dependent totally on a governor. It depends on a county. So one county A will work very well and do things in the right way. The other counties, then you have to go on strike. Like now, we were in our National Advisory Council in Naivasha. We had to issue strike notice for 30 counties. So it means that the other counties are doing what ought to be done. Like Nani County will do what ought to be done, but then Mombasa County will not do this and will not even comply with the court orders. So that, in essence, means that the standardization of healthcare in each and every county will be very different. And for us to really standardize and have it that if you go to an hospital, you get the care, we need to have a uniform where you have workforce in each of the counties employed, and then you have ability to even have them promoted without having all this unnecessary strike. Now, payment of salaries, you realize some counties will go 3 months, 4 months. But with Health Service Commission, just in similar manner, we have the Teacher Service Commissions and the Police Service Commission. It then means that there will be a budget that is directed only for the health workforce. That is, the budget will not be diverted by the county leaders to construct hospitals or to do something else. And if you look at the manifesto again of the Kenya Kwanza, they say they're going to have health service commissions to mitigate the differences and the issues of training between the national government, and the counties. You saw yesterday the health committee talking about the health service commission. It has been a conversation, but I can tell you that the people who are benefiting from the chaos may not allow you to see any light.
It will not happen. You don't see it happening.
I mean, there are those who are benefiting strongly. I mean, if you go to counties, you'll get a lot of ghost workers.
I see.
Yeah, and you realize that the ghost workers is a way that counties benefit directly from the issues of HRH.
Okay.
Yeah.
So let's take a break. But Dr. we are not the only ones in the room. We have very many fixers who are also joining us in the room. And we have them joining us on social media. They are live on YouTube, on Facebook, on X, on TikTok. And you'll be seeing the comments coming in. Look at that. That's our TikTok feed. And after the break, we'll also be hearing from them. So if you've got a question, an issue to raise with Dr. Davji Atellah, who's the Secretary General of the Kenyan Medical Practitioners and Dentists Union, please post them, and then also we'll post the phone line. We'll pick up some calls for some direct questions. This is Fixing the Nation, one conversation at a time. Back shortly. Davji Atellah, we are talking about the state of healthcare, looking at it from the angle of those who treat us, and they're the ones that we find in hospital. They're the ones that in the first part we're looking at their own welfare. And I think there's a question that you had not responded to directly, right? So as a union, because this is your day job now, and all your members look up to you, when we say that 8 doctors committed suicide last year, and most of them, if you look at it, you see it's because of their working conditions. This is truly, truly unfortunate. 4 of them being interns. These interns are our young Gen Z doctors. And they're getting out of university. They are excited. People are coming for their graduation. They are happy now. Sasa Daktari ndio huyu posted. And then you hear that this young budding doctor committed suicide. What are you doing about it? How do we fix this? How do we fix it for all doctors who are working, that they do not have to worry about it anymore?
With the union, the issues or the problem that is affecting one doctor affects the entire doctor family. And that's why you saw it last year, that in the occurrences of any of these events, we were not letting it be that it's just the intern doctor issue. It was an issue of the entire doctor fraternity. For example, and when the Kiambu matter took place, we asked for questions. We wanted answers from that particular facilities, and we don't want answers when you're working. We had to close first the entire county services to get to know what really happened. And to the point that now when we saw these matters were not being handled, we had to ask all the interns, I think on 3rd of November last year, to all stay at home so that this matter can be resolved. And that's why it took us, and after the interns stayed away for 1 month, we then said, no, it's not only interns affected here, it's even the doctors. And that's why they gave the notice for the December. Ideally, it's an attitude problem. And then it's a situation whereby those who are entrusted with the responsibility of ensuring that services are delivered, that the welfare of the patient is taken care of, that the doctors who are actually taking care of these particular patients are supported, always sleep on this job. They always do not care. They only want to. There's more of a PR services that governors, that their government actually has, where to them, as long as the door of the hospital is open, not everything is okay. Whether patients get care there, whether the doctors are able to offer the services is an issue to them. And that's why we say this can't be solved individually. It has to be solved with the union, where workers say no. It's for all of us, and it must be done in the right way.
Is access to psychosocial support generally an issue within the union, with doctors, with interns? Because it seems like that's one of the things that is ailing the health sector, is access to psychosocial services. Otherwise, it's very difficult for people to then be able to access these services when they're struggling with their mental health.
It is a problem because, as I can tell you, that based on the structure of the hospitals and the services now, as a doctor, as a health worker, you don't even have leave. So to have audacity or to have the courage to ask for the support to be support when you need it, there's a problem. There's no safe space even in those facilities, and that's why we are trying to keep on bringing it up. That there's need to have these safe spaces for doctors, for health workers, that they can also have debrief, that they can be treated in the right way. If you've not been paid your wages for 4 months or 5 months, like it's happened in Kiambu, you've not been paid for 5 months, and you expect it to be in the hospital. When you say, no, pay us our salaries, then the county strike you from payroll for another 5 months. Those are the situations that we deal with every day in those particular facilities. So it requires a joint, or rather an overall engagement with the employers to understand what value are they getting to us here. It should be a framework, actually.
Yeah.
Would it be something that the union is open to? Like, should you be at the negotiation table again, that there is something about, psychosocial support in whatever return to work formula or, collective or bargaining agreement that you come to?
I can tell you again, the policies on mental health,
yes,
or even the Act, Mental Health Act is there, and these the question of the documentations of this is not a problem.
They exist, yeah.
We have, I would say, in excess of documentations and laws and policies on how the mental health ought to be done, just the same way we have for all these labor matters. But the implementation and the execution of the same is the problem. That do the employers have the morality to actually see that these things are done? No, that does not exist. And that's why we have to have these conversations all the time.
Dr.
Yes.
We are going very, very over the top on this one. Okay, it's a direct matter. There's a doctor today, young or old, who is feeling the burden of what they're doing versus living life versus adulting, and they're facing the pressure. What is the avenue for them to get psychosocial support? Is it there in law that, a county should have a counselor that a doctor goes to or a worker goes to? Is it there in the union that says that as a union, we've come up with a framework that says, doctor, please call this toll-free number and you shall talk to a psychiatrist or a psychologist, somebody who will talk to you. We're offering this support. What's the direct way to handle this?
That actually exists. We have a wellness committee, and we have a joint program with associations, that is the Kenya Medical Associations, Kenya Dental Association, Pharmaceutical Society of Kenya, with the union. And at one point, it actually started during the COVID-19, that has a toll-free numbers for this particular engagement. But that courage, or rather that ability of somebody to make a call to that number becomes a problem. And that's why it is important that these issues, because most of their occurrences and most of the steps that are taken are reactionary. People will just react and say, this is the problem that has occurred after it has occurred, after the event. But it has to get down to the person at that hospital. How do they feel courageously that they have a safe space that they can speak with their colleagues, that this can be identified? For example, in Nakuru, we had a case in 2022 where a doctor, a gynecologist for that matter, took his life, died by suicide, and also for the children. But this doctor, before this event, had engagement with the colleagues, and nobody could see anything until the point that this had happened. We also again had a doctor, again in Nakuru, this was again early last year, who, up to the time that he was taking his life, he had told even his colleagues bye-bye, and he left the social forum. So that existence of the toll-free numbers, the existence of these avenues, that if it doesn't guarantee the doctor that you have a safe space, that you are not going to be stigmatized when you come out and speak about this.
So why does it not? Look, you're saying that this is a framework that's been established by the Kenya Medical Association, together with the union, together with other professionals, to sort out professionals who have spent years in school just understanding even how our brains work. But they don't feel confident to call a fellow doctor and say, I'm going through a problem.
I'm not okay.
If doctors don't have confidence in psychosocial support, how do you expect the rest of us then to actually react?
It boils down to where this comes from. And this is a problem of the working environment. It boils down to the culture that has been put here, where the employment system actually just tries to pitch the older against the younger. The seniors against the juniors. You get the point? So that confidence, it gets down into the working environment that has been put in this place. And that's why we keep saying that and ideally, if you are an intern in the hospital, where you know that despite whether you are sick or whatever the situation, you must be there for the 24 hours. That you are a doctor and you are a consultant, and you know that you are on call, whatever the situation, you must be there. Because without you, then there's not. We have had doctors losing their lives in theater. We saw that in MTRH. We saw that in Nakuru. We've seen that in Mombasa. Why does that happen? Does it mean that this doctor was not feeling the pain when he's in the hospital and then he collapses and dies? It's just the reality of the working environment. You are rather modeled or cultured to just go do the services
and to push
because
yourself.
of the situation in the environment.
Right.
Yes.
I want to transition a bit to Shifsha, but before that, we do have a caller, and we'll also touch on Moi Teaching and Referral and what's happening there and why the strike notice. But we have a caller coming in from Baringo.
It's Edward. Edward, good morning. So Edward is calling in from Baringo, and we'll pick his call, and you respond to that, and then we transition into the Shifsha conversation. Edward is joining in from Baringo. Edward, what question do you have for Dr. Atellah this morning?
All right. Hopefully we'll get back to Edward in a minute, but this transition to Shifsha has been very hectic, as we've seen for patients. The government seems to also not know exactly what is going on. How do we implement this in this amount of time? How do we transition people from one platform to the other? What does that mean for healthcare and for doctors themselves? I think that's a perspective we've not had. How has the transition from NHIF to SHIF and the Social Health Authority, etc., looked like for patients who are, the ones doing the grunt of the work as far as the healthcare of this nation is concerned?
They say the road or the path to hell is paved with good intentions. And ideally, if you hear the conversations and the message that the president has been giving regarding the Social Health Authority and the universal health care, there's a conviction that he wants every Kenyan to be able to access care, devoid of the socioeconomic status, that if you go to any facility, you should be able to get this care. This is what the minister speaks, this is what the government speaks about. So really the intention that they have is pure. But now when we look at this document, on this act and this bill, which also, at one point, I remember when we, in 2023, we came out very strongly to highlight issues with the SHA, like on just at a bill point, where we felt like the inputs that we had shared were not taken in. But that's now water under the bridge. We have Social Health Authority. So our stand as a union on Social Health Authority, that yes, it has challenges, but it must work. Because if it doesn't work, then you're going to have even doctors, they should not be having any jobs. Yeah. Because how would you be the hospitals to offer services when the patients can't afford it? And that insurance that is we're overpaying in it, cannot support. To be at that point, the biggest concern as we speak on SHA is not the issue of inpatient. The inpatient component of it, where you are admitted in a public hospital or in a hospital, that one, this coverage.
It's working.
It's working.
Okay.
And the only difference that will be is that it depends on the procedure that you are undertaking.
Yeah.
If the procedure, for example, is that which exceeds the limit that they put, then you will pay the extra. But that inpatient aspect is working. But then the outpatient component of it is sending many patients into suffering, into disillusion. And this has been well evidenced in outpatient facilities. If you visit any level 5 hospital that before had thronging lines of patients coming in to seek care, it has gone down.
Is the solution to continue with, Shifsha, revert to NHIF? Is there a third option? What's ideal?
The first option in this Social Health Authority is to allow outpatient services. Because in outpatient, as I said, patients go to these hospitals, level 4, 5, and 6. And you're being told, because you're not referred from level 2 or 3,
then we can't.
You have to pay cash. And therefore, most of them end up going back home, not seeking this care. And we have report of outpatient pharmacies having expired drugs because they had projections, but now they can't have these particular patients. So that outpatient component of it is making many Kenyans not to access the care.
Do the level 2s have the capacity to deal with even the small ailments that people are meant to go there, and then get referred, etc.? Or is that a whole other different?
Level 2, 3 facilities in this country are a shell of facilities. They're just buildings with maybe one health worker who then has to do everything in it. So it can't do what I expect it to be. So the model of Social Health Authority, it can work in a context where the doctors in level 2, level 3, that are under labs, the functional labs and everything, which is not in our context here. And that's why there's a big problem. So If that then can be changed, then I think a little bit there could be more hope. But with that, the way it is, it then causes the problem that we have. The next thing is the benefit package. They seem reduced. And therefore, and there's one thing. There's an aspect of chronic fund, there's an aspect of emergency fund.
Yes. Could I put a pin in that so we can get a caller and then come back to the chronic illness fund? Edward, good morning.
Good morning to you.
Say hello to Dr. Atellah.
Hello to Dr. Atellah and all the panelists.
Good morning, Edward.
Muulize swali yako.
Okay, my question is just about a group of clinical officers and also laboratory technologists, because it doesn't really involve doctors, but I believe we are one body as health workers. So I just wanted to inform the panelists that a group of clinical officers and lab techs were actually employed by Global Fund through the Ministry of Health in 2009. And throughout there have been promises that they are going to be absorbed, and up now we are not absorbed. Our contract came to an end on 31st of December 2023, and we were given a 6-month contract by the government under the Ministry of Health. When that contract came to an end, we have been seeing messages and letters from Global Fund, communication between Global Fund and the Ministry of Health. Global Fund is saying that they promised, the Ministry of Health promised them that the staff are going to be absorbed. And the ministry is saying it's in the process of absorbing. So since 2009 and up to now, there have been processes of trying to absorb us. And now we have been without salary since now for 7 months. This is the 7th month. January was the 7th month.
How many are you,
without
Edward?
salary. We were 117, and now countrywide we have been left 94.
Okay.
Spread throughout the counties.
All right.
We have gone for 7 months now.
Yep.
There is no pay, and there is always a resemblance of trying to absorb us, but we have not been given letters of termination of contracts. We are there expecting that absorption is taking place. We are seeing communication between Ministry of Health, occasionally Ministry of Health and the COG. And these things are always ongoing, and we are still just going on with the suffering and hoping.
It just never seems to move. Edward, thank you very much. Let's hear whether Dr. is aware of this and how you're handling it, whether your members are also affected.
It's not only the health workers who are on the Global Fund. We also have actually a total of 8,500 the health workforce that some of them are under UHC program and some of them under COVID-19. If you look at our strike notice of last year, it was part of the demands that this group of health workers be absorbed and employed on the permanent and pensionable terms, because Latif, these workers actually offer services in these hospitals. And by the time that there is this inefficiency, or rather ineffectiveness between COG, Council of Governors, and the counties, and then the ministry, there's an actual aspect of blame game. You go to the county and say, no, you are employed by the ministry. You go to the ministry there, no, you are for counties. But you offer services for Kenyans. So last engagement there was a promise that this was to be sorted actually by last year, by July, August last year. This year, the same thing. They're saying that they're in the process to effect it. Counties are saying they don't have the money. That will be, if you say we absorb them, give us the money. Ministry say, no, we cannot employ these eyes. So that push and pull has been ongoing for a while for this particular group of health workers. And it also has doctors.
How do we fix it?
It boils down to the aspect of the promise in the manifesto of employing 20,000 health workforce by the government or by the government. This has not been done because there is a problem of like when you talk about universal health care, there's an aspect they want credits of everything.
Who owns it?
Who owns it? When you talk about primary health care and community health workers, they say, where should they be? There's no, I would say, patriotism within this sector of health care that the governors and the government side will see like there's need to have this workforce. So there's a lacuna, there's a gap there.
For Edward, is there a way forward for him and 93 of his colleagues?
It's just the same process. The ministry and the council of governors must see the value and the need to actually sort the issue out. Yes. And you see, this is also bring us to this over-reliance on the donor funds.
Donor funding.
Because the Ministry of Health will be like, this money was coming from Global Fund. If they have stopped it, then we have not budgeted, so we can't employ.
Speaking of donor funding, how is this latest freeze on USAID funding affecting the facilities, affecting doctors?
Oh, the USAID funding that was running the malaria program, the HIV program, and the TB program has a big ramification. First of all, you see the health workforce that were, for example, in Ampath, around 2,000 health workers are staying at home. And this is affecting even the HIV programs that were in Nakuru and in all other places in the country. It means then that the patients who are going to seek these services in the hospitals will not get those people to serve them. Let's say that there were stocks of these particular drugs. So there will be no health workers to offer services. So in essence, the impact is immediate. And that's why on one side, the Trump putting American first is a good thing, because we ought to have our political leaders put Kenya first.
I agree.
Because then that means that we will not be crying or complaining right now. There should be an emergency fund that has been dedicated to ensure these programs are not halted, because we don't lack money. We only lack priorities and plans to ensure that these things are executed the right way.
But before we break, really, really quickly, Moi Teaching and Referral Hospital, what's happening there?
Moi Teaching and Referral Hospital, just like all government institutions, has been giving us a lot of promises and promissory notes without fulfillment. So now the doctors are realized that there's no way that they're going to take any more promises. We gave a notice on 2 weeks ago that is ending tonight, and therefore the doctors there have never been promoted. We have doctors in that particular facility that do not have medical insurance. And therefore, you can only seek care as a doctor in that hospital. That if you travel or you get anything outside that particular, outside Eldoret, you don't have any cover. So that happens. There's the discrimination. There's the implementation of the CB that has not been done, despite Kenyatta and KUTRH doing it. So just the same way we always wake these employers who are sleeping, we thought it was the right time to wake up the board of management, the HR, and the CEO to do the right thing. And the only way to do it is to withhold our skills, which you're going to do.
So, Dr. Ari, we thank you very much for having joined us for this conversation. There's a lot more, and there are very many concerns as well, and feedback. And we're saying, join us in this movement. It's a movement that we're creating to fix the nation. Join us in the movement. When you come on, just say, hello, you're here. Whether you're joining us on YouTube or on Facebook or on TikTok or on X, and even on Instagram, just come in and say, you're here.
That's right. Thank you so much, Daktari. We're about to get into the next hour, but we have some news coming in about miners in collaboration with police spent yesterday, Monday night that is, trying to rescue 12 people who are trapped inside a gold mine in Museno village, that's in Shinyalu in Kakamega County. A total of 20 miners were buried alive inside a shaft they were working in after the walls of the mine collapsed. Rescuers managed to pull out 8 out of the 12, but there's still 12 remaining. Area residents, of course, spent their whole night basically trying to get the 12 out. Patrick Legami, who is the deputy chairman of the Union of Miners, has said that lack of proper equipment hampered rescue operations. And of course, sub-county police commander for Shinyalu, that's Daniel Mukumbu, has confirmed the incident. We'll keep you updated as we get more information, but those are some of the pictures from what was going on last night in Shinyalu.
This issue of miners, artisanal miners, and the support that they get. Remember, there's a time when some miners were trapped and they stayed in underground for very long, and it keeps happening. We have to fix it, and we'll address it. In the next hour, we continue the health conversation. We'll be joined by Helen Aura, who's an NTV reporter. She's the one who covered the story that we were talking about yesterday, cancer burden, through journalist lens. She'll be telling us about this patient that she went and covered her story all the way from Kwale, coming to Kutra with her, and just how then this exposes our health system. Keep it here. We are fixing the nation, one conversation at a time.